Thank you all. I'm Dr. Brian Madden, and thanks for that nice introduction, Anna. And this is Dr. Andre Yu. So we're happy to be here. So I'm going to let Dr. Yu start off.
Yeah, so, we just really wanted to have a really great introduction of, what to expect, if you've been referred to palliative care or if you're hoping to meet with a palliative care and supportive team member. We're a very big team made up of not only doctors, but nurses, nurse practitioners, social workers, and chaplains we work closely with chaplains as well. A brief overview of what we're planning to go over today is what is palliative care and supportive care. How do we help patients with brain tumors, and how do we provide this care and when as well. This is a quote from Atul Gawande, who's well known in the palliative care community. Has done a lot of great writing about palliative care and mortality. So we've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It is to enable well-being. And I think Atul Gawande is someone that we really read quite frequently, and is someone that inspires us as well. So what is palliative care? The quote unquote WHO definition from 2017 is a active holistic care of patients of all ages with serious health related suffering due to their illness, especially of those near the end of their life. It aims to improve the quality of life in their patients, the families, and their caregivers. Another similar definition by the Center to Advance Palliative Care is a specialized medical field for people living with serious illness. It's focused on providing relief from the symptoms, the stress of their illness, and to improve the quality of life for both patients and families. And honestly, this is a pretty difficult, I think, to sort of wrap your mind around what this really means. And really what it means to me is, getting to know patients and families, getting to know them as a full person, and what they're going through, try to, understand, what's going on socially, mentally, of course, physically, with their care, along with their families, and try to support them, with all these different team members, and work very closely with all these team members as well. And the goal really is to, my goal, and I think I speak for both of us, is to really get to know, the situation, and see how we can improve quality of life, and, with whatever that means, and a lot of times it's, not even the physical symptoms. It's a lot of, coordinating care. It's a lot of addressing spiritual and existential distress, and really, honestly, listening and, figuring out what's most important to you as a person and you as a family as well. So, what does that look like? How do we do that? And so, a lot of times we ask, very general questions to begin with, along with, the symptom management questions. But, really, we try to initiate meaningful communication about what matters most to you and to family members. So really, what are you hoping to achieve? Because a lot of times there's things like trade-offs with serious illnesses in terms of symptom relief or, length of life. And our goal is to figure out, who you are as a person, how we can improve things and, from different facets. And, if there's any question about, different areas of, the medical aspects, is to really educate and, like a lot of the techniques we use, like, teach back, making sure you understand what's going on with your illness and what we're hoping for and what, you're hoping for, and helping to, bridge that gap if there's a difference there as well. So, honestly, a lot of it is listening and getting to know people too.
So I'll kind of take it from here. When we talk about having communication, I think, and we use the elephant in the room metaphor, because oftentimes this isn't something that people really want to engage in a conversation about, And I think a lot of physicians were never really trained on how to have these conversations. And there is now a lot of data on how to approach these subjects in ways that will engage people, starting with the idea of what do you want to know? Because sometimes it is perfectly as appropriate for patients to say, I don't want to know what's going to happen to me. You can tell my family member, my spouse, my children, and they'll make decisions to wanting to know everything and be fully make their own decisions even when they can't, and make them ahead of time. So our process is to first ask those questions, and then depending on what you want to understand or know, to talk about that. Again, as Dr. Yu mentioned, the sort of teach back is very important so that we know that patients are really grasping what's happening and do understand it in their own language and in their own terms. Talking about the future and what the potential prognosis might be. We mentioned hopes, fears, and trade-offs, which really gets to the question of trying to figure out what makes a quality life. We try not to put our own opinions or bias into that, but to really find out what's meaningful to you or to the patients, and then to include the process of bringing family and friends in who will be there to help you with the journey, because it is a journey. We understand that. So that's the communication piece. And then the other part of what palliative and supportive does is, of course, deals directly with symptoms, pain being the most obvious one. Nausea, vomiting, shortness of breath, fatigue, anorexia. I mention those because perhaps the fatigue and anorexia are more common to see in brain tumor patients. Thankfully, we usually don't see a lot of pain, although it can certainly happen. Dr. Gowernathan's going to talk a little bit, more about the mental health side of it, but certainly that's something that we would also recognize and try to assist with. Also, I think with our chaplain, social work, and the psychosocial support that comes with palliative care and with cancer supportive services in general, are dealing with the existential issues of our mortality and kind of beyond just what you would consider traditional mental health diagnoses. The other things that we provide are talking about who gets to make decisions and helping patients pick surrogates if necessary, filling out paperwork such as advance directives, which gives you an opportunity to express your wishes in general terms about what you might want if you couldn't make your own decisions, to help guide your surrogate as to what to do. And often in those advance directives or related to that are what we call code status. I put it into quotes because it might not be that familiar, but that's issues around whether we should put someone on a ventilator to help them if they couldn't breathe, whether we should restart a heart. So those are conversations that are worth having well before those issues become a crisis. We also, as I mentioned, provide psychosocial support. I think the one detail there I didn't already mention is facilities, because sometimes it becomes hard to care for people at home, especially with brain tumors if it's causing significant challenges with their caregiving. So we can help along with social work in the supportive services to help that. And then, of course, I think where we're often confused is with hospice, because palliative and supportive doesn't mean you have to give up anything really as far as treatment. You do not have to have a 6 months or less prognosis. That's actually hospice care. So we would help refer to home hospice or to any hospice when appropriate. Sometimes we are involved with patients here at the hospital that can't go home and might end up dying here in the hospital, and we would assist making sure that that is comfortable. So we certainly can do hospice, but I would say that's a piece of the larger bubble of palliative care, and not only what we do. So this kind of brings it all together in a nice chart view where all of these different aspects of what make us human and what is important to us all kind of come together in what we call the whole person care model, and trying to look at the whole person and address all of these issues and how they might relate to each other. So to kind of conclude on this, I would say that, not just us, Dr. Yu and myself, but I think Dr. Garinathan, Anna, your oncologists, the neuro-oncologists, radiation oncology, primary care, everybody does do palliative care. We all are learning. I say we may not all be trained, but we're all learning how to improve our communication skills, talking about difficult issues, and of course, primary symptom management. I mean, we're not the only ones that can treat pain or these symptoms, where we find ourselves often becoming involved or in complex situations, and sometimes having to do what I said there was competing goals. Sometimes, we have to discuss if treating pain aggressively may inhibit or may assist the ability to continue treatment, and different locations of treatment, how life-sustaining treatments, for instance, might inhibit the ability to continue treatment, such as being on a ventilator sometimes could do that. And then, of course, when it does become an issue or it becomes something to talk about, is its transitions to hospice, which we're often involved in, or again, patients who might remain in the hospital. So with that said, I think we are just a part of the overall supportive care services team that Anna mentioned, and that Dr. Garinathan's going to talk about next with psycho-oncology. We have, again, additional social work, nutrition. So we're very happy to help everyone and to be a part of the bigger team. So thank you very much. And we'll pass it on to Dr. Garinathan and stick around for questions at the end.
Next question is for Dr. Madden. My husband was told his cancer is incurable and he's on a treatment, and we were told that we would only have 1 year at best. I think it's a good time to start talking about it now, but when is a good time to start talking about palliative care, or is it time for hospice?
Yeah, so that's a common question that we get. We talk about palliative care, we call it a surprise question, usually asked to doctors, saying, would you be surprised if this patient were to die in a year? And if the answer to that is no, I wouldn't be surprised, it's possible, it's not necessarily the prognosis, as you said in this case was a year, then it would be very appropriate to talk to palliative care. So again, there's no prognostic requirement. I would say it's not time for hospice if you're more than 6 months, and the other side of it, and if there are still treatments that seem to be offered and might still be beneficial, because once hospice starts, then disease-directed cancer treatments usually stop at that time. So I don't think it's too early, because it's never too early to start talking about what's important in life and to make the best of what time there is, since we never are fully sure.
And this question is for Dr. Yu. It says, my dad has GBM and we all support him, but he isn't ready to talk about the future. Do you have suggestions on how I can bring up the conversation about end of life?
That's always a hard question, I think. That's one of the questions that I always ask patients themselves is, how much do you want to hear, and how much do you want to know? And for some people, they don't want to know, at the time, but then as things are, progressing, they want to know more. And for other people, they trust their family members and they defer to their family members. And so it's their right to, the amount of information that they want to know. And, I think, if there's a significant amount of distress, going on with family members having to make those decisions for someone who doesn't want to know, that's another part that we are helpful with and sort of talking through these issues. And, even if they don't want to know, we can help with talking about what they might want in this, scenario X, Y, and Z. And, it can be very stressful to have to make those decisions for family members, for those people. And sometimes, people change their mind with things where they wanted to know everything, but as things are progressing, they want to know less, and vice versa as well. And so, we always try to go in with a, pretty open mind about, how much they want to hear. And, we never try to force, that information on them if they don't want to hear it too. So, I would say just keep an open mind. And if they don't want to hear that information, then, continuing to ask them as things are progressing. And if they don't want to know that at all, then that's okay. We can, work through that too.
Is palliative only for inpatients, and does insurance cover palliative or hospice?
Yes, I'll answer that. So we do have inpatient, and we have office-based practice. We've been doing that mostly virtual during the pandemic, but we do have space to see patients next to the hospital. And it is covered by insurance. It's routine, like seeing any other physician. Hospice is actually, though, a change in how the insurance pays. So that one is different in terms of how it affects who you're seeing. I mean, we won't go into all the details about that, but I would say it is covered, but it's covered with changes. So that's why palliative care doesn't change anything about insurance and is covered normally. So to consult with one of us is just like consulting with cardiologist, psychiatrist, any of us.
And honestly, it's really nice to meet people as an outpatient and not necessarily inpatient, where, there's always, emergencies that we're trying to put out on the inpatient side. I think the outpatient, it really gives us, time to really get to know someone, know where their values are. And, so, we can help make decisions with you guys as well.
As a person who may have been newly diagnosed with a brain tumor, what is one piece of advice that you could give them to help them on their journey?
That's one piece of advice. I guess, just from our world, don't be afraid to ask questions. I think it's very common to feel so overwhelmed that you forget to ask things. You feel like I know we see it a lot. People feel like they need to impress their physicians, show that you're stoic, show that you're strong. It's okay. It's okay. However you are, wherever you are. Ask us questions, tell us how you feel so that we can help you. We aren't going to not try to achieve your goals because of that. So it hurts you more not to tell us than it does to tell us, because it doesn't really hurt you to tell us.
One piece of advice that I would say is to try to keep doing things that bring you joy or thinking about them. It's really easy, when you're getting treatment and have a new diagnosis to, be focused on the next thing that you have to do in terms of treatment, the next doctor, the next imaging you have to do. But, even as simple as, like Dr. Garanadian was saying, go outside and, be outside for a little bit of time. Don't lose sight of, what you're doing all of this for. And, take those small joys when you can.